Hello, Dr. Virenga and everyone else. Thank you for the kind introduction. Can you hear me?
Yes, we can hear you loud and clear.
Okay, thank you very much for the kind introduction, as I said, and also for giving me an opportunity to share on this very important topic. What I'm going to talk about is on fetal growth restriction screening, diagnosis, and the management protocol after this diagnosis. Now for my discussion, I'll first of all begin with the outline. I'll just highlight my outline. I'm going to define what fetal growth restriction is, and then highlight the extent of the disease burden, and then I'll go on to screening, and then I'll touch a little bit on the recognized phenotypes for fetal growth restriction, and then finally, I'll go to the diagnosis and management. Now, by definition, we say that a fetus has fetal growth restriction if they are failing to achieve its genetically predetermined growth potential. Now, what I want you to realize that at a particular time when you're looking at the baby, when you're examining the baby by ultrasound scan, we actually don't know what the growth potential of the baby is. And also what we know is that growth is actually a dynamic parameter. And because of this, this is actually a functional definition which seeks to identify fetuses which are at risk of modifiable but otherwise poor outcomes. Now, fetal growth restriction, as Dr. Verenga has clearly pointed out, is a common and very complex problem. It affects, on average, 10% of all pregnancies, but this varies depending on which population is actually being looked at. And what we know is that fetuses with fetal growth restriction are at increased risk of perinatal morbidity and mortality, and also of long-term complication. In childhood, that is, if they manage to survive the perinatal period or the neonatal period, they're at high risk of growth delay and neurodevelopmental impairment. Whereas in adulthood, they're at high risk of non-communicable diseases, which are characterized by high blood pressure, dyslipidemia, central obesity, and insulin resistance. And later on, they present to the physicians with type 2 diabetes mellitus, coronary heart disease, stroke, chronic hypertension, and to the gynae with polycystic ovarian syndrome. But within the same breath, I also want to mention small for gestational age. Dr. Verenga has also already mentioned it. This term is easy for us to handle as clinicians. It is used to define a fetus whose size by biometric evaluation is falling below a predefined threshold for its gestational age. And most studies actually use the 10th percentile of the given reference range, which means that if the estimated fetal weight is less than 10 centile, then we say that the baby has is small for gestational age. But what I want to highlight is that small for gestational age is not synonymous with fetal growth restriction. Within the small for gestational age group, there are 3 distinct subgroups: the constitutionally small fetuses, the pathologically small fetuses, and also the starving small fetuses. And also what we have realized that some babies with fetal growth restriction may actually not be small for gestational age. To try to highlight this, on this graph that's here, what we see are babies who are small for gestational age, but then they continue to grow following their growth trajectory. And these are healthy small babies, but who are small for gestational age when you plot them on this graph. Whereas these other babies on this line here are small for gestational age, but also they begin to fall off their growth trajectory. These babies are not only small for gestational age, but they also have fetal growth restriction. And already Dr. Verenga, I think, has already discussed these babies. When you plot them at one particular point in time, you find that we define them as appropriate for gestational age. But if you continue measuring the estimated fetal weight, you find that they begin to fall off their growth trajectory. And these babies, although they are not small for gestational age, actually have fetal growth restriction. Now, in this study which was done by McCowan and others, you'll note that babies who are small for gestational age actually consisted of these 3 groups. Those who are normal small, these are constitutionally small babies who are healthy. And also there were abnormal small babies, which formed 15% of these. When we say abnormal small babies, what we mean is that they have some other pathology, which is causing them to not grow so well. Like they have chromosomal abnormalities, congenital abnormalities, or even congenital infections. And then we have this small group, which is starving small, which due to uteroplacental insufficiency is failing to achieve its genetically predetermined growth. And when we talk about fetal growth restriction, we want to restrict ourselves to these babies who are starving small, and also these ones, they are also starving, but they are within the appropriate for gestational age a quota when you look at them before you start plotting their growth serially. And also, Dr. Vedenga, as he has pointed out, these babies should ideally be properly dated. The pregnancy should have been properly dated so we know what gestational age that they are. So our challenge as clinicians is to identify the fetuses with fetal growth restriction whose health is endangered in utero because of a hostile intrauterine environment. Now, in terms of screening, traditionally, what have we been doing? And we are still actually doing it. We're identifying women with pre-existing risk factors for fetal growth restriction who come to our clinics. And then later on, as the pregnancy continues, we also assess the acquired complications that they have in that pregnancy, which also make them at high risk of having a baby with fetal growth restriction. And then also we are clinically examining the babies to find out the symphysis fundal height, and then also decide whether they are at risk of fetal growth restriction. But all these are fraught with errors. Some women have no pre-existing risk factors at the time when we see them. And then when we look at the acquired complications, right now what we'll be doing is playing catch up, because already these people have severe preeclampsia, and most probably the baby already has fetal growth restriction. And finally, when you look at clinically, when you're examining the baby, the mother, the symphysis fundal height, this is also very difficult to correlate, as the mother may have other abnormalities, like if she has fibroid uterus, and also if there are things like abnormalities in amniotic fluid volume, this may all lead to a wrong diagnosis. More recently, we've added on the Doppler velocimetry and placental biomarkers in screening of women for possible fetal growth restriction. In terms of the Doppler velocimetry, what we do is we interrogate the uterine artery Doppler. What we know is that normally in pregnancy, there is physiologic transformation of the uterine arteries from high to low resistance vessels. This occurs firstly within the first trimester due to trophoblastic invasion of the spiral arteries of the mother. And later on, it continues into second trimester. There's a first wave and the second wave. The end result is that they form low resistant blood vessels. Unfortunately, if this process does not occur at all, or if it is insufficient, then there is persistence of high uterine artery resistance in the vessels. And this will be noted on uterine artery Doppler as a high PI, which is more than 95th percentile, and or diastolic notching. And once we have this high PI, which is greater than 95th percentile, including or without diastolic notching, then we say that the mother is at high risk, the fetus is at high risk of having fetal growth restriction. This is a normal uterine artery Doppler that we should find in first trimester, towards the end of first trimester, and also later on as the pregnancy continues. Whereas this is an abnormal uterine artery Doppler with notching that you can see here. This is the notch. Now, screening using the Doppler velocimetry will identify patients who are at high risk of fetal growth restriction and preeclampsia. We can start this screening as early as at the 11 to 13 week scan, and we can also do it later on when we do our anomaly scan at 19 to 23 weeks. At the 19 to 23 week scan, it often helps us to identify patients who are at risk of late onset fetal growth restriction and or preeclampsia. What I want to highlight is the subsequent normalization of the uterine artery Doppler in women who had an abnormal uterine artery Doppler at 24 weeks is still associated with a high risk of fetal growth restriction. So the women should still undergo surveillance, even if their uterine arteries become normal. And then for biomarkers for fetal growth restriction, it's quite an area of great interest currently, whereby lots of markers have been looked at. But what I want to highlight is mainly PAP-A, which is pregnancy-associated plasma protein A. This is a protease that determines the availability of insulin-like growth factors and is released from the placenta, specifically from the syncytial trophoblastic cells. Well, it has been shown that when the concentrations are low in first trimester. These are associated with an increased risk of fetal growth restriction, preterm delivery, preeclampsia, and stillbirth. So these two new screening methods, that is Doppler velocimetry and PAP-A, help us to see babies who are at high risk of fetal growth restriction. And once we are aware of this, they are an indication for surveillance of the fetus through ultrasonic assessment of fetal growth and Doppler velocimetry as the pregnancy progresses. Now, I want to go into tools that we use for diagnosis and at the same time surveillance, as they are interlinked. Some of them will be used for diagnosis and also for surveillance, although there are some tools which are strictly for surveillance. So the tools that we use for diagnosis in this case is the ultrasound scan, whereby we want to do firstly fetal growth velocity, and then we also use the ultrasound scan in the form of Dopplers for Doppler velocimetry. Now, with fetal growth velocity, what it basically means that you're going to measure the weight of the baby, the estimated fetal weight, serially. And when you do that, you plot them, the weight on longitudinal growth charts, which enables assessment of the growth velocity of the baby. And what we want to be aware of as we do this is that is there reduced growth velocity, which we identify when the baby falls off its growth curve on 2 consecutive scans by more than 50 percentiles. What does that mean? You measure a baby today, and then they're on the 90th centile or 70th centile, for example. And then after 2 or more weeks, then you remeasure, and then you find that the baby is less than 20th on the 20th percentile. Then this baby has fallen off its growth by more than 50 percentiles. So this should trigger investigations to find out if this baby is really growth restricted. But what I also want to highlight is that there's consensus that if the estimated fetal weight at any given point in time or the abdominal circumference is less than the 30th percentile, in babies who have been, whose gestational age has been properly dated, is properly known, and who have no other pathology, then these babies can also be diagnosed by just that one scan as having fetal growth restriction. So this is an exception to our normal protocol whereby we are going to follow the growth velocity of the baby. Now, there's also Doppler velocimetry in terms of diagnosis and surveillance. With Doppler velocimetry, this allows us to interrogate different blood vessels, firstly in the mother and also in the baby. In the mother, we will interrogate the uterine arteries and the umbilical artery Dopplers, which will show or identify a uteroplacental insufficiency. And also, we can also do the middle cerebral artery and the ductus venosus. Now, these ones show the babies or the fetal cardiovascular adaptation to the hypoxia that they are undergoing. These Dopplers can be used for diagnosis and also for surveillance. For diagnosis, we mainly use the uterine artery, umbilical artery, and middle cerebral artery. Whereas for surveillance, we can use the umbilical artery, Doppler, middle cerebral, and now that's when the ductus venosus also comes in. As I said, the computerized CTG, if one has it, can also be used in surveillance of babies who have been diagnosed with fetal growth restriction. We can also use biophysical profiles for surveillance. Now, before I go on to the actual diagnosis of fetal growth restriction, I want to highlight the phenotypes that are there in terms of fetal growth restriction that we now recognize. We can divide fetal growth restricted babies into those with early onset fetal growth restriction and those with late onset fetal growth restriction. Why it's important to do that, the basis of this distinction is basically that the onset of fetal growth restriction in those with early onset is earlier than 32 weeks, whereas the onset is later than 32 weeks for those with late onset fetal growth restriction. But why it's important to highlight this is because their characteristics are also different. In terms of manifestation, I've already said that if it's early onset fetal growth restriction, it begins earlier than 32 weeks. But the prevalence also is less, that is it's 30%. And then the ultrasound findings, usually these babies are very small. And then the Doppler velocimetry, you'll find that there's derangements in all the Dopplers, or there may be initially some Dopplers which are deranged, but as you continue monitoring the pregnancy, all of them may actually become involved in the derangements. And these patients, often the mothers are hypertensive. And also what we've noticed that the perinatal mortality is often high for these babies. The main clinical challenge in this case is management, but it's very easy to recognize these babies with this fetal growth restriction. Now, in terms of the late onset fetal growth restriction, what we've noted is that it tends to be more prevalent, 70%, and then the ultrasound findings may not be really very specific, as the babies may actually be appropriate for appropriately grown. And then when we look at the cerebral blood flow, when we look at the Doppler velocimetry, we find that cerebral blood flow may be the only thing that is abnormal with redistribution, plus or minus sometimes a little bit of derangement in the umbilical artery Dopplers. And then often these patients may actually be normotensive up until the end of pregnancy. And then in terms of perinatal mortality, we find that it may be low if these babies are recognized in time, but sometimes because if you fail to recognize them, then it may increase the perinatal mortality. In terms of detection, it is very difficult to detect these babies. And then now the diagnosis of fetal growth restriction is based on an international Delphi consensus. What this basically means that a group of experts came and then said and then decided that this is the best way that we can diagnose fetal growth restriction. And early fetal growth restriction has a certain criteria which is a little bit different from late fetal growth restriction. With early fetal growth restriction and both late fetal growth restriction, if at any given time the estimated fetal weight or abdominal circumference is less than 30 cm, this is enough for us to diagnose these babies with fetal growth restriction. But now if you look at the early fetal growth restriction, also umbilical artery Doppler, if there's absent end diastolic flow, then in this case also it's sufficient for us to say that these babies are growth restricted. But in addition, we can also look at babies who are small for gestation. This is the diagnosis. If the baby is less than 10 centile, then we say the baby is small for gestational age. In addition, if the uterine artery PI or the umbilical artery PI is more than the 9/5 centile, then we may say that these babies have fetal growth restriction. Whereas for late fetal growth restriction, in this case, if also the babies are small for gestational age, what we'll do, we'll need to follow up the growth trajectory. And if they follow their growth trajectory by more than 2 quarters or by more than 50 percentile, then in that case, we say these babies are growth restriction. We can also look at the CPR. The CPR basically means it's cerebroplacental ratio, which means the middle cerebral artery PI divided by the umbilical artery PI. And if this is less than the 5th centile, then in this case, this also shows that this baby with late onset fetal growth restriction has late onset fetal growth restriction. It is basically measuring and quantifying the brain sparing effects seen in placental insufficiency. Once we have made a diagnosis of either early or late fetal growth restriction, we put the babies under surveillance. What are our surveillance goals? First of all, we want to assess at every given point when we see the babies, whether there's fetal hypoxia and or whether there's acidosis and what's its extent. We want to see how fast these babies are deteriorating. And then are they now at risk of intrauterine edemas and or stillbirth? Should we administer antenatal steroids and also magnesium sulfate? That is, if we see that we may need to deliver early. And then also we need to plan for the appropriate interval to next review or for the next assessment. And then also want to decide on timing of delivery. These are our surveillance goals when we look at babies who we've diagnosed with fetal growth restriction. Okay, and then in terms of the scenarios that we may meet for babies who are who have fetal growth restriction at less than 32 weeks of gestational age, we have 3 scenarios which we often come across. Scenario 1 is that we've confirmed that the baby is fetal growth restriction, but at that point in time, the Dopplers are normal. So the surveillance will consist of growth scans and Dopplers, which should be done every 2 weeks. Whereas in scenario 2, where we have the identified fetal growth restriction, and now the Dopplers are now abnormal, which may be in the form of high umbilical artery PI and low middle cerebral artery PI. In this case, then we want to see these babies every week, and then we do weekly Doppler scans. In scenario 3, there's fetal growth restriction and abnormal Dopplers, but in this case, they become severely deranged, whereby there's absent or reverse end diastolic flow. In this case, if we're not yet delivering, then we need to do Dopplers every 3 days. And if available, then we'd also want to do computerized CTG. If not available, we may also do the conventional CTG. And then how do we make a decision to deliver for these babies with early onset fetal growth restriction? Using the Doppler criteria, if there's absent or reversed A wave in the ductus venosus, this is the ductus venosus. So if there's absent A wave is here, or if it's reversed, then in that case, then we should deliver. This was shown by the TRAFO study that this is the best way to monitor these babies and to decide on delivery, that the ductus venosus should be the one that guides us in terms of when to deliver. And this delivery should be done urgently within 24 hours. Now, in terms of surveillance of late onset fetal growth restricted babies, there are also 3 scenarios that we come across. Fetal growth restriction with normal Dopplers, that is, we do our 2 weekly growth scans and Dopplers, just like in early fetal growth restriction. Scenario 2 is different though. In this case, yes, there's fetal growth restriction, and the only thing that there's elevated umbilical artery Doppler PI. So in this case, we do weekly Dopplers with biophysical profile score. And then in scenario 3, there's low middle cerebral artery PI, or the cerebral placental ratio is low, less than 5%. In this case, then we are going to see these babies every 2 to 3 times per week and do Dopplers with biophysical profile as well. The decision to deliver in this case will be based on umbilical artery Doppler and middle cerebral artery. The ductus venosus has no role to play in late onset fetal growth restriction. If the umbilical artery PI is high, greater than the 95th center, or the MCA is low, less than the 5th center, then we must deliver this baby as soon as they arrive at 37 weeks. If at any given point in time, if the end diastolic umbilical artery is for the umbilical artery is reversed or is absent, then in this case, delivery must be done immediately at any given point in time, that is after 32 weeks. We still have fetal growth restriction, but the Dopplers have remained normal up until term. Then in this case, we want to deliver at 30 to 39 weeks of gestation. Let me hasten that to say that at any gestational age, delivery is indicated if the following are present. If there are spontaneous, repeated, persistent, unprovoked heart rate decelerations using CTG, whether this is computerized or conventional CTG. If there's altered biophysical profile in the babies with late onset fetal growth restriction, if the biophysical profile is less than 4, then we should deliver. And then if there's any maternal indication, such as eclampsia, HELP syndrome, or obstetric emergency requiring delivery, such as abruption, then in that case, again, we should deliver. We don't continue surveillance with the Dopplers. Most babies with early onset fetal growth restriction end up being delivered by cesarean section because they are quite ill by the time a decision to deliver is made. Whereas in late onset fetal growth restriction, we may induce depending on clinical situation. In this case, ideally, we should use continuous fetal heart rate monitoring using CTG during labor, as these babies can easily decompensate. And let me end my talk with this slide on Zimbabwe to just show the Zimbabwean situation in terms of screening and management of fetal growth restriction. We are now able to screen for fetal growth restriction using uterine artery Doppler. We are not using PAP-A. It's only, I think, centers in England and also some developed countries which have begun using PAP-A for screening for fetal growth restriction. And we can do this Doppler velocimetry at 11 to 13 weeks for babies or for mothers who present early in time. And we can also do it at the 18 to 22 weeks anomaly scan. But this is mainly if they present to our centers at our tertiary centers, because right now, those who are doing a scanning for first trimester in the private sector, most of them are not able to do it. So they need to learn how to do it so that we can spread it all throughout Zimbabwe. In terms of monitoring, usually once the baby has been diagnosed with fetal growth restriction, they are referred to our tertiary institutions, the fetal medicine units there. And our staff or the people there, the fetal medicine units, are the ones who do the scanning. So we're also able to follow up the babies. And counseling of the expecting couples is also done in conjunction with the fetal medicine staff, in conjunction with the obstetricians. We have no computerized CTG for surveillance. We do have some CTGs, but they're not enough to be able to do surveillance for all the babies with fetal growth restriction. This is conventional CTG that we have. And then most babies affected by fetal growth restriction in our setting, they end up being delivered by cesarean section, as we are not able to do continuous monitoring with the CTG intrapartum. So this is the Zimbabwean situation where we are currently. Thank you for listening.